Thank you very much, Richard. So I'm going to talk about compensatory pelvic tilt. Title of this talk is, does compensatory anterior pelvic tilt and lumbar lordosis decrease following periacetabular osteotomy? We have no disclosures pertinent to this study. So the relationship between the lumbar spine alignment and mobility and acetabular position has been appreciated for a long time. It's a source of clinical conundrum for us, and it is not really quantified at the present time. We know that compensation for insufficient acetabular coverage can result from involuntarily increased lumbar lordosis and anterior pelvic tilt. And we also know that we have insufficient good techniques to measure this tilt radiographically. This is the clinical observation that stimulated this study. You can see on the left there's a significant pelvic inlet view, and following bilateral periacetabular osteotomy, taking a standing x-ray, the pelvic inlet appearance has largely resolved. So our hypothesis is that patients with acetabular dysplasia may compensate for insufficient anterior acetabular coverage by increasing lumbar lordosis and thus anterior pelvic tilt. And we created a new index called the Pubic Symphysis to Sacroilliac Index to enable us to try to measure this observation. And this is based upon the sagittal diameter of the pelvic inlet increasing with increasing lumbar lordosis and decreasing with decreasing lumbar lordosis. We feel that the pelvic tilt can be quantified by measuring the sagittal diameter of the pelvic inlet. And this is the way we do the measurement. We draw a transverse line between the sacroiliac junction of the sacroiliac joints, a vertical perpendicular to the pubic symphysis, and we measure that line in millimeters. Our questions for this study utilizing that technique is inter-observer reliability of this novel measurement of pelvic tilt clinically useful, and can alterations in the PSSI index, as we call it, on the standing AP pelvis x-ray quantify tilt? So this was a single surgeon cohort. We selected 40 patients who underwent bilateral staged periacetabular osteotomies enrolled as part of our anchor cohort study. And we reviewed standing AP pelvis x-rays preoperatively and a minimum of 6 months following the second surgery, and measured tonus angle, the anterior wall index, the posterior wall index, the lateral center edge angle, and the new PSSI index. We had 35 females and 5 males in this study. The mean age at the first PAO was 21, mean BMI was 23, and the mean standing x-ray from the second PAO was 16 months. We performed an inter-rater reliability assessment on interclass coefficient, and our reliability was excellent. So all further analyses were performed by averaging measurements between observers. The data distribution was assessed with the Shapiro-Wilk test, and we used Pearson's correlation coefficient to evaluate changes between the PSSI index, lateral center edge angle, tonus angle, posterior wall index, and anterior wall index. So we then constructed a validation model of pelvic tilt using a sawbone model of the pelvis mounted to a jig, and we took a simulated standing AP pelvis x-ray and then tilted the model in 5-degree increments from 0 to 30 degrees, and we measured the PSSI index at each degree of tilt and then performed a regression analysis looking for trend and to come up with a arithmetic equation to predict the degree of tilt. This is our sawbone model, and the regression analysis demonstrated, not surprisingly, a linear relationship between the PSSI ratio and tilt, such that for every 1 millimeter of tilt, that represented 3.6 degrees of pelvic. For every 1 millimeter change in measurement, that represented 3.6 degrees change in the pelvic tilt. So our inter-rater reliability for using the PSSI index is excellent. It's a very easy and reproducible technique. And we found a statistically significant change between the pre- and post-operatively measured PSSI index. The mean change was 8 millimeters, which represents approximately 30 degrees in change of pelvic tilt following the second PAO. 92.5% had a decreased anterior pelvic tilt following the second PAO, and 7% had no change. So we found that although there was a statistically significant increase in the lateral center edge angle, decreased tonus angle, and posterior wall index from pre-op to post-op, we could not find any significant change in the anterior wall index. And we found no correlation between the magnitude of change of the PSSI index and the measured changes in acetabular coverage. It just changed, but did not correlate with the magnitude. There are, of course, limitations to this study. There are no size markers used on all of the x-rays, although they are digitally obtained and fairly reproducible. And there is no real quantifiable study of pelvic dimensions. Therefore, the PSSI index may not be applicable in every specific pelvic morphology subtype. In conclusion, the PSSI index is a novel, simple, and reproducible technique to assess pelvic tilt on the AP pelvis film. Following bilateral PAO, the majority of patients were found to have a lower PSSI index and thus less anterior pelvic tilt. And the PSSI index, based upon the sawbone model, demonstrates a linear relationship with the change in pelvic tilt. Why do I think this is clinically significant? First of all, we have to start measuring the pelvic tilt. It factors into how we decide on reorientation of the acetabulum. And this should be a routinely measured marker now, I think. Acetabular reorientation affects the position of the lumbar spine and thus pelvic orientation. Involuntary compensation for acetabular dysplasia is dynamic and clearly reversible. Our current static measures of acetabular dimension do not adequately account for dynamic lumbopelvic orientation. And finally, when positioning a patient for a PAO, you have to be very careful to try to take into account the degree of pelvic tilt that a patient presents with on their initial standing x-rays. Thank you very much.